been holding hearts before charts, before meds had names, we had compassion. This one's for every nurse, past, present, and future. Let's go.
We are the calm in the storm, the beacon of hope. Every beat, every breath, we honor the oath. From night shifts to day breaks, loving our tone. Peplo taught us, connection heals more than alone. From Florence to futures, we redefine care, not just meds and machines. We're presence of prayer, with hands that comfort, eyes that see truth. Healing ain't a chart, notice what we do. We are nurses with hearts wide open.
Welcome back, everybody. Good to have everybody here back. Another episode of Peplow's Ghost. Welcome to my new guest here. Really looking forward to Dr. Kris Vandenberg Harrison. You know, it's a small world. When I met her a few times at conference, the International Society of Psych Nurses, I don't know why. I was just kind of drawn to her a little bit, and then found out that we have kind of a career connection of both presenting for Dr. Barkley's board prep stuff. So it's a small world. We know Dr. Barkley, send our love to him. No need to send our love. He's doing well. I don't want to kind of get everybody anxious and like, oh, something wrong with Dr. Barkley. Nothing's wrong, but it's just a fun thing that Kris and I kind of share with. I'm also shared with my colleague and friends, Dr. Kate Molino from California and Dr. Melissa Chapman-Hayes from Minneapolis. So thanks again for everybody. And thank you, the listener here, for joining us and such. So I'm just going to kind of get into it, Kris, and really kind of tap into your vast knowledge and understanding. You're a seasoned educator, experience in the psych mental health field for over 30 years. I hate to say that number, but
that's okay.
You must have started when you were 11, so that you look great. And this is an audio podcast, so I'll just share to people. But would you mind kind of just taking us through that time? Thinking of this as Peplow's, Ghost podcast and her history of birthing our profession here in 1950s and such. What have you seen in your practice, shifts on how, advanced practice nurses operate, how the psych mental health nurse practitioner program practice has changed clinically in education? Just kind of take us through what you've seen and kind of start us off that way.
Sure. Well, taking you all the way back to 1991, I guess, was my first time to experience any psychiatric nursing. And I was a diploma nurse. So, the white dress, the white cap, the Peplow, therapeutic relationship was center, number one to nursing. And I've definitely seen that evolve through the 30 years. I'm embarrassed to say that as well, but it's been a nice, refreshing 30 years. What I'm really excited to see is how we're almost bringing things back full circle. And there's so many of us now talking about the importance of integrating psychotherapy back into our medication management practice. I definitely have seen a lot of evolution throughout the years.
Yeah, even the diploma nurse. Wow, that's something that some of our new graduates who might be listening have to look up what that is. I mean, that's that's a good old days of the white dresses and the pinning and I like this idea of cyclic stuff. Anything that kind of stands out for you that you've seen that's more specific on the cycle of psychotherapy and its role, like you said. Maybe when you're going through and getting your diploma, you heard about this new person called Peplow, but now she's kind of one of our patron saints of the practice and such. But what else have you seen that's what's old is new again kind of thing?
Oh, good question. What's old is new? I think meeting the patient where they are and hearing their story. That's how I learned to be a nurse was you got to sit down and you have to learn who the person is, talk to them, say, tell me about you. And for so long, I did that. And then things started to change where we had a lot of patients we had to see. I saw the break between therapy and psychology and medication management. And it was like, what do you do? Are you a medication management person or are you a therapist? And I was like, well, why do I have to be one or the other? And so for many years, I struggled with that. And how do I blend the two? And I have been fortunate in being an educator that I've been able to have students who I blend the two together and say, you don't have to choose. You get to be a nurse, number one. That's what I tell my students. You're nurse number one. You're a psychiatric nurse practitioner number two. And so being able to blend both those pieces, I think we're really starting to see it come back. How do I see that? Just in my own practice, my patients will tell me, they're like, thank you for listening to me. I know you're not my therapist, but I appreciate you taking the time to listen to me. So it's funny how even they see a difference between, there's therapy and there's med management, and I'm trying to show them how we can blend the two, and they appreciate it. And I think many of our patients are asking for that.
Yeah. Yeah. Very well said. Thanks, Kris. I mean, I love that example. And reminds me of just an experience I had just this week in the clinic. And I had a psychologist come up to me and, thank me for, taking a person that she referred to me. And I kind of was a little embarrassed. I was like, well, I don't think I did very much for her. She didn't need a medication. I just kind of talked to her a little bit and we kind of did some things. And she's like, no, that was perfect. And the patient loved that, just, being there and connecting with it. So yeah, it just kind of emphasizes what you said. So thank you. I'll turn it over to Kate. Oh, Kris, I don't know where I came from. Kate.
Yeah, thank you, Dan. So Kris, I'm interested, you talked about your background in education and how you've seen firsthand how our PMHNP curricula has really evolved over time. I'm curious, similar to along the lines of what Dan was asking, what do you see as, the biggest gaps or friction points between what students are taught in graduate school and then the actual day-to-day realities of NP clinical practice?
I find this with my students in simulation. Oftentimes they'll say, well, you're not giving me enough information. I need more information. I can't make a decision without enough information. And so trying to really teach them that when you're in the real world, you only have so much, you only have what you gather or what has been given to you. And teaching my students that over time you evolve with a patient. You might change the diagnosis, change their medications, or change how you approach them. And I think in education, it's you see a patient, they give you the symptoms, you diagnose. And really, in true reality, it's not that way. You have to get to know the patient before you can actually formulate a whole diagnosis or treatment plan. So that's the biggest gap, is trying to get them to say, it's okay. I don't know everything in the first visit.
Yeah, that's so insightful. You're right. It is a really, we are making the decisions we make based on the best information we have at the time, which is always changing. Yeah. And so, teaching students to sort of hold that a little bit of uncertainty that's a really important skill for them to have.
Yeah.
Yeah. Thank you. Yeah. I'll pass it to Melissa.
And my question is going to really play off of what you just said and what Kate was asking. So how do you help students or trainees develop true clinical intuition and nuanced diagnostic skills when dealing with complex real-world cases where they will have partial information or need to make those judgments about how to move forward?
That's why simulation is so wonderful, because we can actually guide it that way and give our students not all the information and teach them how to move past that, get to know the patient, figure out what questions they need to ask. And it allows us to see what is their intuition and help guide them. So often in clinical experiences, it's the provider really leading the visit, and students aren't allowed to necessarily practice, their intuition. What way would I go? I have students all the time come to me and say, it's so frustrating when I'm in clinical because in my head, I've formulated a whole plan and then out of my preceptor's mouth comes something completely different. And I say to them, that doesn't mean what you were thinking was wrong. That was your intuition. That was your way of guiding the treatment plan. And so in simulation, we get to do that a little bit more. So we're fortunate at UCCS where we have a simulation clinic. Our students are all across the country, but they come in like telehealth visit. So they don't have to come to campus, but we have a budget where we have a simulation lab and we have real patients. Well, they're not real patients, but they're actors who simulate patient experiences and allow them to kind of navigate through that a little bit more. I'm not sure if that quite answered you, but.
Yeah, I think so. Yeah. That's having simulation would be as close as they can get to practicing, since they're not able to make those determinations as students.
Yeah.
Yeah, I'm wondering, and maybe I'm just kind of seeking some validation here. I know, just simulations in general. I follow students, from that first simulation when they're very, very nervous and kind of don't know what to say, and so they get really anxious. Until you see them, and we just had our students, kind of complete their last simulation, and I'm just like, you're ready to practice, just kind of put the stamp on them and say, you're ready.
Yeah.
In your simulations, do you ever kind of maybe take the opportunity, is a great way to say it, to throw them some curveballs and maybe kind of,
Absolutely.
how do you think about that and what sort of curveballs do you mind kind of sharing? I'm sure none of your students will listen to this podcast, so you can share all your secrets.
Well, I mean, that's a great question, Dan. Recently, I had a group of students working together, and it was a whole put together simulation about depression. But what I felt was that they were having a hard time communicating therapeutically. So I'm like, I'm going to switch this up. These are students about to graduate, and I just want them to feel like it's okay to just talk with the patient. So that was a huge curveball because what they were looking for was diagnosis and medications and therapy. I was like, I just want to talk. I'm not sure that I want to do medication, or that's how I had the actor portray. I'm not sure that I even want to do medication. I just want to talk about it. And that, it seems so simple, but for students was really challenging because they had to go back all the way back to what is a therapeutic relationship and how do I just talk to my patient? Even as they continued to educate the simulated patient or the actor, I guess, we would bring them back to, well, no, I don't want to be educated. I just want to talk about it. I want to tell you how I feel about it. And getting them to focus in on more open-ended questions. And these were graduate students, some of them being doctoral students. So they were really challenged. I mean, this is, nursing 101, therapeutic relationship, but being able to give them that opportunity to practice that, they all afterwards were like, thank you, that was so far out of our comfort zone. And to me, it should be not. It should be within your comfort zone, right? As a nurse. So that's kind of a curveball just recently through my students. That was fun.
Yeah, thank you. That's great.
Mm-hmm.
I mean, I love this idea. And I think that's, obviously goes to your expertise in this too. I think, thinking of a faculty member too, it's that idea of, checking all the boxes, making sure the students kind of have everything, but your experience and your expertise and, understanding what a student needs when they graduate to feel comfortable. It's not always, and I try to say this, at least once or twice to my students too. You don't need, every appointment doesn't need to come away with a prescription, but
Right.
something, they need to leave with something, and so
Right.
sometimes we can't have that physically. So yeah,
And
that's
sometimes
great.
being heard is all they need to leave with.
I think
know,
that's
that-
huge. Yeah, I think that's
Yeah.
so much more valuable to people, but hard to quantify that as always. Yeah.
That is true.
Mhm. So, Kris, I'm curious. You hold dual certification as both an FNP, family nurse practitioner, and a psych nurse practitioner. How does your grounding in primary care influence your psychiatric diagnostics and clinical decision making, especially when you have patients with complex somatic complaints or medical comorbidities?
Yeah, and let me make one clarification. I am dually educated. I'm no longer certified as an FNP. I was at one point, but it just was kind of too much for me to keep up with. So as far as, it's hard for me to even think back to what it would be like to practice without having that dual education. Because when I see my patients, I see them holistically. I know that's kind of a catch word we throw around, but I do. I'll give you another example. I saw a patient recently who had been through numerous psychiatric providers, primary care, and nobody could treat his anxiety. And as he sat in front of me on telehealth, I just said, tell me about your anxiety. Talk to me about it. Give me more information. And I just sat there for 20 minutes and listened to him. And I thought to myself, I don't know, this was an intuition thing with having the dual education. I was like, this is not psychiatric. This is not anxiety. And I can't quantify and tell you why it's not, but it's not. And ended up getting him in with a neurologist, and he was later diagnosed with a neurological condition that was not anxiety. I'm sorry, I can't remember what it was off the top of my head. But that's something that being exposed to both medical and psychiatric conditions together, that it's hard to teach. It definitely is something you have to experience. I will say with my patients, it's a little bit more difficult on the flip side when they have more somatic complaints. And then I'm trying to tease out, is this psychiatric? Because this guy, he had no somatic complaints other than he was shaking and he had anxiety. It was Huntington's. That's what he ended up getting diagnosed with. Huntington's. So it had been missed for about 2 years. So it is a little bit harder for me when people are, with their medical, because there's that FMP in me that wants to go, well, I just kind of want to fix that, you know? And so trying my best to tease those out the best I can.
Well, thank you. I love how you illustrated sort of how your two streams of training can work together and also how
Sure.
they can battle a little bit and
Yeah, oh yeah.
conflict. And that's really useful.
Yeah.
Okay, so over your esteemed career in psychiatric practice, I'm sure that you encounter patients with persistent mental illness, treatment resistance, and complex trauma. What clinical strategies or frameworks have proven most effective for you in sustaining long-term therapeutic engagement with these patients?
Ooh, that's a difficult question. I think meeting the patient where they are at that time. I can come into an appointment with a very preconceived idea of today we're going to talk about, you know, a little bit about your trauma and how the medication has helped with some of the symptomology that presents with that trauma. And my patient may walk in the door or on telehealth and they're not even ready for that. They want to talk about the car accident they got into yesterday or their kid that yelled at them. And being able to, that's taken me many years to be able to say, okay, my plan doesn't have to be implemented today. Matter of fact, I don't even have to mention it. I can just sit back and listen to my patients and the complexities, with trauma so often it it ebbs and flows when patients want to delve into that or and deal with it. And it's taken me a lot of time to learn that I just have to be present with where they are at that moment and meet them where they are.
Well, I imagine there's a lot of trust then because you're seeing them where
Trust.
they're
Yeah,
at. And
absolutely.
so
Yeah.
to maintain that long-term relationship,
Yeah.
trust is that number one building block.
I would say if my patients could tell me one thing, that they gain from me being their provider is that they trust me. If I ever hear that, I mean, that is just gives me goosebumps because that is everything that I want to do as a provider is to be there for my patient. And I will often tell them, I'm here for when things completely fall apart in whatever way, whether that's your fault or not your fault. I'm 100% here not to judge, but to help you figure out how to put the pieces back together. And that's the trust.
Lovely. Thank you.
Mhm.
Yeah, I mean, yeah, it's so very well said. And I got to ask the next question, just kind of, maybe going off that too. I think, again, maybe thinking from, beginning practitioner students who might be listening, the challenge always, I think, is to keep them coming back, right? So that beginning part of that therapeutic relationship is oh so important. But I think, again, based on your experience and how long you've been doing this, I think there's another side of this that, can present some challenges. And I'm wondering if you can speak to this maybe a little bit, after you've been seeing somebody for 5, 10 years, maybe even more, what sort of challenges, come up with that kind of longevity in your relationship with
Oh,
a patient?
sure.
Thinking maybe some countertransference or other things, but
Yeah.
what are some things that maybe come to your mind that present themselves in maintaining that trust in that relationship we were just talking
Sure.
about over long periods like that?
I think the hardest part is keeping the boundaries within that therapeutic relationship. And I mean, it can be something as simple as if I've seen someone for 10 years, in my head and in my heart and in my soul, they're my friend, number one. And being able to say when they walk in the door, okay, yes, you're my friend, but I'm your provider and you're my patient. And being able to separate out those two, it's been very challenging. I recently had a patient after 14 years asked for her records because she was going somewhere else. And I live in a small town and I ran into her and she, kind of hi. And we talked for a minute and I said, can you share with me a little bit about why you're going with someone else? Because I mean, it really bothered me for months knowing this. And she said, I just feel like we got too close. And I appreciated that from her. It was wonderful feedback for me to get because we had, the first thing that we would talk about was, oh, how are your kids doing? And, how are things going? How's the weather? Just friendly conversation. And at that point in her life, she needed a provider, not a friend. And it really set me back to think about the patients that I've had for a long time and how I need to remember to respect those boundaries and that sometimes they need more than me. They need a fresh set of eyes. They need someone that doesn't know their whole history, their whole baggage. But that's challenging emotionally for me because I develop a relationship. I like to say that I have great boundaries, but again, I'm a person, and in my heart and soul, it's hard not to be a friend to somebody.
Wow, thank you for that vulnerability and just the
Hmm.
I would say the confidence that it takes to kind of share those kind of things. Because what I heard there too is you were open to the idea that this is a learning experience for you as well,
Hmm.
and so really applaud you for, taking that extra step and learning
Yeah,
from, it's one of those things I try to remind myself as well. I try to make sure that I'm not learning more from the patient than they're learning from me, but there is definitely a
right.
dynamic there where I continuously learn from patients all the time. So
All
yeah,
day
thank you for
long.
that experience, that
Mhm.
example.
You're welcome.
And I'd like to pick up on that a little bit. Just,
Mhm.
something you mentioned, Kris, about living in a small town. And, we know that NPs are often positioned as providers who are working in smaller areas, more rural areas,
Right.
whatnot. And that kind of can come with its own set of challenges when we are
Yeah.
providing mental health care. I'm curious over, the last couple of decades while you've been doing this work, how you have learned to draw boundaries or, guidance you give
Yeah.
to your students working in this type of setting.
Yeah. One thing I've done to help myself is I've expanded out with telehealth, outside of my small community. I would say as a provider, one of the challenging parts is feeling like I failed a patient when I see them not doing well. It's not only did I fail them, they're living in my community. I failed my community now. And so I've kind of had to do that a lot with my students. I talk to them about how that feels. I'm like, that's a very valid emotion to have when you're treating someone down the road and then you see them relapse or they end up in jail. You feel like not only you failed them, you failed your whole community. So I have been very good about, simple things like my husband goes to the grocery store. I don't. The shopping, I shop out of town. I have a primary care provider out of town. I try to separate out some of that. So, because I don't want my patients to feel like I'm here in this community watching them as well. I want them to have that freedom. But being able to, there was one point where I said, "Oh, I'm just going to take care of my community because that's what I need to do." And then I realized for me as a provider, that was hard. I needed to take care of other communities as well, ones that weren't part of my everyday, going to the grocery store, the post office, whatever it might be. So I teach my students, it's okay especially if a patient acknowledges you and, out in public to say hello to them. But you have to remember that they're just living their life too. That's not an appointment. You don't have to feel bad about what's happening with them at that point. I don't know. It's a hard one,
I
really
think
hard.
so. I think I'm just going to take away from that the way to get rid of a lot of chores in your life is to work in a small
Exactly.
town, and you can
You've
offload
got it.
that to your partner, right? Yeah,
That's right.
that's great strategy. I love it, Kris. That's great. Melissa.
Yes, thank you. My head went to actually when I lived in Iowa City and I saw a provider, and I just remember the provider telling me, because Iowa City is like 80,000 people, right? But
Yeah,
you see, it feels smaller than that. If we see each other in the grocery store, I'm probably not going to acknowledge you, right? And
right.
that's kind of the boundary that she had set. Like, it's not
Hmm.
personal, it's just a boundary, or
Right.
however she said it. Yeah.
Yeah,
Okay, question.
sure.
My mind went back into my memory. So actually, this goes along well with a number of things that you've shared today. Psychiatric nursing demands high emotional bandwidth, and burnout among new grads is a growing concern. What advice or practical self-care boundaries do you stress to your students and early career colleagues or any colleagues to ensure they build a sustainable lifelong practice?
It's funny because I have what I call a behavior lab with my students where we just talk about emotions and feelings, and it's an optional thing that they can be a part of. But one of the things I always say to them is, I'm not going to give you all that mumbo jumbo self-care talk, because when people tell me to go do yoga and do meditation and all these things, I do not do that. That is not me. And for so many years, people were like, well, you need to do meditation. You should work out more. And what I need to do is talk more. That's what's therapeutic for me, to go to a conference and run into Dan and be able to just have a conversation about something. Those are the things that relieve me. Hearing someone else who's stressed a little bit in their job, or that they have to meet the AAC essentials, something. So we all have different ways of coping. And I think we've gotten into this little box as nurses of being able to say, meditate, do yoga, do all these things, and realize that's not where everybody finds their self-care. So just being able to expand outside of that, there is a high burnout. And I was one of those nurses. I was one that applied to law school, that got into law school, that said, I'm not going to be a psychiatric nurse anymore. And what changed that was recommitting to education, saying, okay, before I go to law school, let me go on and get a graduate degree. Maybe that'll prompt me in a different, or move me in a different direction. And I did a full qualitative study in that master's program where I asked patients what it was like to be locked up in a unit. And the words and voices I heard from them to this day impact how I am as a nurse. It forever changed me, because as they told me, they felt like they were being herded through a process, and that they had no control. It made me step back and think, who am I as a nurse, and how can I change that, shift that whole paradigm? And that's what helped me with my burnout. It wasn't going to yoga classes or meditating. It was diving deeper into nursing. So I think we have to just take different approaches on what self-care may look like. It doesn't always mean, being away from nursing. It might be digging deeper into nursing.
It sounds like actually finding like your purpose and drive and why for doing it came from that qualitative study. And thank you for the self-care comment, because as a same, like mindfulness is great, breathing's great. And yes, we need to not box people. So like you need to do.
My students always giggle and say, thank you, because if one more person brings me pizza and then tells me, to have a quiet moment, I feel like I'm going to go insane myself.
Right. Counterproductive.
Oh, so man, that's so great. And I would just say too, I think this podcast has really kept me from burning out. So thank you for the listeners, and thank you for Kate,
Love
Melissa, and Kris, you too. It's something that fills my cup. So the next, what we'd like to do here is have a recording of our previous guest, Dr. Kathleen McDermott. She's going to ask you a question, and we'd love to hear your response on the other side. So here we go. All right.
There we go.
All right, as we're doing here, we're asking the question for our next guest. Thank you, Dr. Kathleen McDermott, for asking question for Dr. Kris Vandenberg. What do you got for her?
Hello, Dr. Kris Vandenberg. I look forward to meeting you at some point. My question for you, I've stalked you a little bit online to learn a little bit about you. I understand that you've been in practice for a long time. I have too. I'd be curious, I'd be curious to hear your thoughts on the evolution of psychiatric mental health nurse practitioner practicing. I'd be curious to hear your thoughts on how things have evolved over the course of your time practicing. And if you're open to it, even beyond that, where do you see practice going? What's your hope for that? And does that align with what you're seeing currently? Can't wait to hear your thoughts.
Yeah.
Thank you for the question. And I think we've talked a little bit about the evolution of the psych nurse practitioner and how it's coming back, or I feel like it's coming back full circle. Now, that might be because in my long career, I feel like I'm coming back full circle. So, where do I see the psych nurse practitioner role evolving to? I want to see it come back to the integration of really getting to know somebody versus just the prescription management. Here's the pill, here's the script, go, go, go. The more the merrier, the more the money. And again, I've practiced a long time. So that's kind of going back to what I always envisioned myself being as a nurse practitioner. But there's definitely been a lot of evolution.
Yeah, there has. And so I'm hoping that there is still a practice in our future as well. And, I think that's what we do as educators, to try to, leave a little bit for the next generation and the next group of students that we take care of. And, Yeah, I always like the comments that sometimes we say at our college, we are training people to take care of us in the future. And so let's do a good job because
I hope that is true.
yeah, we all hope that's true, right? So, well, thank you again, Dr. Kris Vandenberg and Harrison. Thank you so much for being our guest. This has been a true pleasure, and thanks for sharing your expertise here with us. Those listening, we'll have another podcast episode soon, and you'll hear from Kris again with another question for our future guests. So thank you so much. Keep listening, like, subscribe, add comments, again, share those who want to be with us too. So thank you so much, and look forward to a new episode coming soon.
Carrying the torch through the blood and the rain. We are nurses, the world can't forget. We give our all, no regrets. Modern in our ways, but our roots don't decay. Nurses anthem, and it's here to stay. We are nurses.
So here's to the hands that heal, the hearts that stay steady, the voices that whisper you're not alone. Because nursing isn't just what we do, it's who we are.